Welcome to Nipton Talks. I'm your host, Dr. Ashley Robey, and with me is Dr. Christopher Zarella. Thanks for coming on, Chris.
Yeah, thanks for having me.
Can you tell our audience a little bit about your background and your training experience?
Yeah, so did I did a plastic surgery residency with you, right, years ago.
Yes.
Yeah, my chief resident, right? And
Okay.
anyways, I did general surgery before that, and then plastic surgery, and then after that, I did a pediatric craniofacial fellowship in Washington D.C. at Children's National Medical Center. So my specialty is craniofacial and pediatric plastic surgery. So cleft lip and palate, skull surgery. Part of cleft lip and palate, I do rhinoplasties, which is what we're going to talk about today. So I've had a really nice teenage rhinoplasty practice that I've
Nice.
cultivated, which has been really nice. So not much other cosmetic stuff though.
But no, that's perfect. So, today we're talking about rhinoplasties, rhinoplasty, rhino meaning nose, plasty meaning surgery to change the appearance, shape, function. When people think of rhinoplasties, classically they think of the term nose job because that's certainly encompassing that. For rhinoplasties, there are kind of two broad categories, namely an aesthetic or cosmetic rhinoplasty, but also a functional rhinoplasty. The truth is that most rhinoplasties involve a combination of both. And I think that's one advantage to having someone with experience in the functional component, and certainly obviously in craniofacial surgery. You're right there, and me with my ENT background, that's we spend a lot of time working on the functionality, and one should not negatively impact the other. There's certainly a way to make both of those things be as harmonious as possible, and a good rhinoplasty surgeon will certainly achieve that for you. So from my perspective, I think that rhinoplasties, I mean, they're kind of a mixture of a really fun surgery, but also a really challenging surgery. It's one of the few surgeries that I do where I still make a pre-planned list of approach. I am writing down all the things that I want to address, and then I have specific maneuvers that I think I'm going to be utilizing during that specific surgery to achieve those goals. And sometimes like what you see and what you think you're going to see aren't exactly the same. So, I mean, the plan is like, okay, I think I'm going to do this, that, or the other, and I have a listed approach, but it's not always the same. And then by the time I'm dictating the operative note, I crossing off the things that I didn't do or adding on things that I did do. But yeah, so for every patient, I'm basically looking at photos, writing down the things that I had talked about in the consultation note with regards to what the patient's goals are, and having a list approach to the exact techniques I'm going to implement. I mean, I can't say I do that for a tummy tuck, but rhinoplasty, I think, is a little bit of a different bird. I think the other challenging part with rhinoplasties is that from a literature perspective, and I don't think this specifically holds true for me, from a literature point of view, they report about a 20% revision rate. So 1 out of 5 people is either thinking about or is getting a revision nose surgery. And I think that's because the nose is in the middle of the face, and you can perceive if it's a 1 millimeter off the midline, whereas let's say if one breast is 1 millimeter lower than the other, no one's going to know or care. And now we live in an age of selfies and video calls, Zoom calls like we're on now. And you just constantly get this feedback, like you're looking in the mirror, like, oh gosh, you just see yourself all the time. And so it's hard to not pick up on some of those asymmetries. And so I think the popularity of the procedure has increased. Um, has that been your experience as well?
As far as popularity, I mean, my practice is different because these are referrals from pediatricians, and so everything. Usually, I get a rhinoplasty referral with a functional component, right? Because the child or the young adult will have had concerns for breathing issues, and then the cleft lip and palate rhinoplasties, the base of the nose rests on the top of the lip, so they always have some. There's always some deformity to the nose. You try to correct it at the initial operation at the lip repair, but still, they always have severe septal deviation in my experience. So really, all the rhinoplasties I do come to me with a functional concern. I mean, a lot of the teenagers when they come in will say that they have a concern for cosmesis in addition to the functional concern, but it's a little bit different because of my age, the age bracket that I take care of.
Sure. My patients are more of coming in for aesthetic concerns primarily. And then, oh yeah, by the way, if I'm taking a really big breath in, like my nose will collapse or something like that. But yes, most people do have a little bit of both. It just sometimes leans more heavily toward a functional or an aesthetic approach. Now, I know for your cleft patients, obviously you're doing some nose surgery at an earlier age, but for the patients that you're treating for the functional, the young adult teen group, from a functional perspective, what do you have an age limit or minimum that you recommend or require?
I always tell the parents skeletal maturity. So really when they're done growing, and I usually say 15 years, 15, 16 years for girls, and then 16, 17 for boys. I won't do it younger than that.
No, that's
Um,
fair.
yeah.
I agree. Like you don't want to be operating on someone when they're still growing. It just makes the ability to hit that ideal shape or position, if it's truly functional, it makes that quite difficult. The other component when it comes to younger patients is the maturity. I mean, you could be skeletally mature, but if psychologically you're very immature, undergoing a rhinoplasty, not that it's a huge procedure, but it's not a molar removal. So it's comparatively a big surgery. And there are definitely some psychologic and psychiatric things that we as surgeons want to take into account and make sure that, the patient's doing it for the right reason or reasons. And even more importantly, that they have realistic expectations. That's true for anyone, regardless of being immature or mature. If you are expecting this to change your life, make your life all of a sudden something grand, if your life is garbage now, then you'll probably be greatly disappointed with your rhinoplasty. I had a patient, and I think I've told this story before, but it's really memorable to me because, and it's not about the nose, but she was working at a fast food restaurant, and she was up for a manager position. And she came in to see me and was talking about how she was just so disappointed because she didn't get the job or the promotion that she wanted. And it was because of this crooked scar on her abdomen. And she knew that if she just got that abdominal scar fixed, that she would have gotten that promotion. And so here she is, she's going to get this scar fixed. And then as soon as she gets that guarantee, she's going to be off, sailing off into the world of managership. So yeah, if that's obviously an obvious red flag, but sometimes people present with a little more subtle idea of inappropriate expectations, meaning the rhinoplasty will do a good job at changing the way your nose looks and or functions. It's not going to change you as a person. It's not going to change who you are or what you're doing in your life.
Yeah, I do to some degree. It can, I mean, it's not going to get you that promotion, that's for sure. But I think the increase in self-confidence that a lot of patients experience after a facial cosmetic procedure really kind of can carry far to improve your life in that way. You know, I mean,
Yeah,
I,
I think that's a nice added benefit, but I think you can't go into it expecting that, right? Oh, yeah, I do feel better about myself, but if you go into it like, I hate myself, and if I don't get my nose fixed, I'm not going to love myself, then I think that's a tough position to be in.
yes, and I agree that would be a red flag for someone who would be a good candidate. I just had a consult with I think 17-year-old, and the biggest concern that he had was the bump
Sure.
um, on the bridge of his nose, as he had said. But he was kind of aggressive, right? Like he plays soccer, and I was like, if you like soccer this much, then you should wait till the end of the season, or when you're done with school, because if soccer is that important to you, you're not going to be able to play for a while. And
Yeah.
so he figured out when he had a break, and so he's like, well, I need to have this surgery in November, right? Like, and he was very aggressive about telling me when he needed to have this surgery, and I'm booked on my surgery schedule, right? And so he
Mm.
was really quite upset that he couldn't have that. Anyway, so I told him he should get a second opinion, right? Because maybe someone else will. Yeah, it's tough.
Now, so one thing that I don't personally do, but I know some people that do it, are the computer generated vector imaging where you're erasing the dorsal hump, but they can also kind of drop and drag different parts of your nose. I've seen it in action. It's
Yeah,
kind of weird.
it's weird. When
Mm.
I first started, I was in a practice that had that. The Vectra was great for breast augmentation, I thought, because you could pick the implant that you were going to put it in, and I thought it did a really good job of like kind of generating what it would look like. But for the rhinoplasty, like all these modifications that right, and I do the same as you, like a very step by step. I type it in my consultation notes so that this way when I go back I read it right. Like, but every technical step that I want to do in the rhinoplasty, and when you change it in Vectra, the modifications to take down the dorsal hump is not this technical modification, right? Like, so it's
It's just
basically like,
like drawing a line and like erasing everything above it.
yeah, you got it. It's basically like Photoshop, not an
Yeah,
actual technical
yeah,
surgical program. Yes. So
right.
I do not,
And then especially on the nose, or just like you click on it and you're like, it just it's weird. And as a surgeon, you're not dropping and dragging the cartilage. It's just not, so it's not representative of what's done anyways. I
yeah,
don't.
I agree with you 100%. And I mean, I take the time in the consultation to tell the patients basically what the technical maneuvers are, or at least draw a picture of what the nasal skeleton, the cartilaginous skeleton of the nose looks like. And I give them basics of what I want to do to that to help get the nose to look the way they wish, or those things that I want to do to improve the function of their nose. And then I think that's more helpful for them to understand how we can get to achieve their goals operatively.
Yeah, I'm not saying things like, oh, well, here I'm going to put in spreader grafts and I'm going to do
Yeah.
like a cephalic trim and those kinds of things. But I do break it down to like, okay, these are the things that I see. Like maybe you have a dorsal hump, like the bump on your nose. Maybe your tip is too wide, it's too bulbous. Maybe it's over rotated or under rotated. Like we're just kind of, I do a set of photos with them. And then I actually, in the beginning of the consultation, like I do a set of photos and then I look through the photos with them. Like, this is what I see. These are the things that I would want to address and incorporate into your surgery. And I don't get into the details because I don't know, some of it's overwhelming. We talk about the incisions and the recovery, but I'm not talking about this kind of graft or, shield graft or, those kinds of things. I don't really talk about that because it's a little bit, it's maybe too much.
Yeah. Well, that I agree. I mean, things that I would talk about would be, I mean, sometimes I will tell them about a cephalic trim, although I don't necessarily call it that, but trimming,
Oh,
and
sure.
I always tell them
Like,
the
I
tip of
want
the
to
nose.
debunk here. Yeah.
Yeah, yeah, and I just say that is what will reduce, right? Like, or I just tell them that I will put some stitches in to modify the cartilages that make the tip, if it's a bulbous tip, if we're gonna, bring it in. And but yeah, I agree with you. Very technical terms like spreader grafts or non-anatomic alar Batchen grafts. Uh,
Yeah.
yeah, we don't talk about that necessarily.
I think there's so many of these grafts out there. Sometimes it's for the plastic surgeon. You're like, what graft is this person talking about? Because there's so many names of various graft techniques. From the perspective of a patient who's finally undergoing surgery, do you kind of could you run through a step by step, like what that would entail? Like, let's say they're ready for surgery. Once they're in the OR, what would
Uh,
that,
as far as uh, as far as like going to
like
going to
you're in the
sleep
OR,
or
then what? Yeah. Yeah. Like
oh
all of the above. Like you do,
yeah.
I'm assuming you do sleep, right?
Yeah, yes, correct. Absolutely. General anesthesia. So, I mean, the they'll have the breathing tube, be fully
Yeah.
asleep, managed by the anesthesiologist. So I don't have to worry about that. Another doctor is taking care of them. And then the prep that I do ahead of time, trim the nose hairs, put local numbing medicine in the nose, and I inject in the septum too. I don't know if you do that, but I find that
Yeah.
helpful. And then prep the face
I
for
mean,
surgery.
are you injecting the whole dorsum?
I do, yeah. Injecting the dorsum and in the septum, which should help with pain at least short term post-operatively, because I use the bupivacaine, the medicine that the numbing medicine that lasts 8 hours, right? And then prep the face to sterilize the skin or reduce the bacteria, and
Yeah.
then drape the patient and start for surgery.
Hmm.
So
And then for your little transcolumnar incision, do you do the inverted V or do you do that little stair step?
no inverted V. Yeah, is that what you do?
Yeah, the stair step, I don't like how it's asymmetric. It bothers me
I
because
agree.
like one,
I
I
agree.
can't
And
remember who did that. Someone that we train with did that stair step. I remember.
I don't know. I can't
I
remember.
think a lot of people do.
A lot of people do. Well, that's like the Dallas Rhinoplasty course teaches you the stair step. The other reason why I like the inverted V is sometimes, especially in like a cleft lip and palate patient, a lot of times their nose might need more
Oh yeah, you
projection.
probably want to, you're closing off the
Yeah,
V.
yeah, you got it. And you could do a V to Y. Uh,
For like
uh,
Asian people sometimes too.
yes, yeah, that would be a good example of. I find that to be advantageous there. Plus,
Yeah,
it
I
just
like
looks
that.
more natural. I mean, when you look under the nose, I mean, that's kind of the way the shape of the anatomy is there.
For the reasons that you mentioned, if the columella needs to be lengthened for people, if this part of your nose here is really short, which is really common in cleft patients, but also common in Asians and some African patients where there just is not a lot of tip height or dorsal height. Often we're looking to utilize techniques that would allow us to expand that. So that B to Y, having that midline incision. When I draw, during my consultation, I usually draw that. No one ever asked me like, oh, why did you do that V as opposed to a stair step? But I think it probably is worth noting if you're someone who's in the market for a nose job, what kind of incisions your surgeon utilizes. That does bring up the whole open versus closed rhinoplasty technique style. So closed rhinoplasty, meaning the incisions are solely on the inside of the nose. So there's none of the transcolumellar or the skin external incisions. Whereas open, in addition to the incisions on the inside, you have the one across the columella. And I do like open rhinoplasties. I mean, I will do closed for, let's say, someone that has just some deviated nasal bones, but that might be a stretch to even call that a true rhinoplasty. The open technique allows you to certainly see everything much more readily. And when the nose is closed, you have to deliver the cartilage into the incision and then make your modifications and then put it back in and then hope it's good. I'm sure some people get very good at it, but I think you have less control. Basically, you have less control over the outcome because there's certain areas that you just really can't see. Like, I don't think you can see the very tip of the nose, and putting in these, sutures that I'm sure that you and I both put in on the tip for symmetry and domal creation sutures and those kinds of things. Your ability to place those is so much more limited.
Absolutely. I mean, the control, and so I've never done a closed rhinoplasty in my life. And so for the small incision that you have across this little bridge of skin here, I mean,
Mhm.
it's tiny, it heals well. You have to be very close up to see it. And what you gain in control of the outcome, like of the control of the maneuvers to get the nose to look the way you want it to, is so superior. I mean, that's like kind of a no-brainer, right? To do an open.
I mean, yeah, that being said, I know that the people that do closed rhinoplasties are going to feel like it's so much better for whatever reason. They just have less swelling, right?
Yeah.
Not the external scar, but that scar is hard to see. You literally have to take a basal view of someone.
Yeah. Although I feel like the dissection is pretty similar, right? Like if you're freeing up the cartilage open or closed, I really don't even know how much less dissection of the nose, of the skin off of the skeleton of the nose because you still need to deliver those cartilages. So either which way, whether you're
Yeah.
looking at them directly or you're pulling them out of the incision, uh, you often express concern that the columella is very swollen and firm after an open rhinoplasty, but it always gets better and softens up. So as long as they understand that they will get there, I think that that's the important thing.
Yeah, so I mean, I guess we're both in agreement. We like open rhinoplasties, not to knock people that do closed rhinoplasties, but I think it does have its limitations. One of the biggest challenge with rhinoplasties is that there's just so little room for error. It's sub-millimeter amount of error is accepted with regards to final position of these structures. And you don't have as much control in a closed rhinoplasty. So I would think that the revision rate would be higher just because of that specific criteria. But as far as post-operative care goes, for me, I recommend that so I put little internal silastic splints and an external splint on as well. And I have patients have those in/on for about a week, plus minus. So once that is ready to come out/off, you can see the results of your rhinoplasty, but right away, it's going to be still pretty swollen. So it's not like that's the final result, but you will see some change immediately upon removal of all the dressings, but it's going to be partially masked by the swelling. So the swelling tends to be the worst down in the tip of the nose because that's where gravity tends to take swelling. Also, that's where the incision is. And the truth is that that swelling, even though the majority of it in the first, 1 to 2 months is gone, there's still tiny amounts of swelling that persist for up to a year after surgery. So that's why when people think about like, oh, maybe it's still too puffy and I don't like it, most every surgeon recommends waiting about a year after rhinoplasty to consider any kind of revision work, because otherwise you would be trying to work on something that's still in flux. And then if you're still not at the new baseline and you're trying to make additional changes, you're just never going to hit that perfect ideal. So yeah, a year before revisions. Again, I don't personally see 20% revision rate, but I put that in my consents because I want people to go into the surgery thinking that that's a real likelihood.
Agreed. Mine, so because I have, it's like a bimodal or two different types of rhinoplasty, really, for the functional and cosmetic ones for regular people, and then the functional and cosmetic ones for my cleft patients. I do think the cleft patients have a higher revision rate because they've already had several. So it's funny because usually I'm pickier with the post-op result on those than the patient because it is so much better than where they started. But again, those cartilages have been warped or whatever shape they were for 15, 16, 17 years. And it's really hard to, I mean, it's hard to really get it perfect, I think. I mean, so they have a slightly higher revision rate than the average person, but that's just a little bit different. But I would agree with you. I don't experience a 20% revision rate for the remainder of my rhinoplasty practice either.
Mhm. So obviously I don't do cleft rhinoplasty, but I have done like a handful of like secondary cleft rhinoplasty patients, just that I don't know, somehow end up on my doorstep saying, hey, can you look at this little zone or this area? And I'm happy to help them. But the same kind of principles really hold true regardless of whether or not you have a cleft deformity or it's truly aesthetic, is that you're just trying to create functional structure that will help support the tissues and symmetry. So the same kinds of techniques I really would utilize regardless of whether or not you had a history of cleft lip and palate, or sorry, cleft lip and nose. So I wanted to get into some of the common misconceptions and myths, and oftentimes they kind of overlap with the frequently asked questions. I know you get referrals, but for me, I'll have patients that will, and this is slowed down, thank goodness, but that will come in and bring in a photo of a couple different, usually supermodels, and say, I want this nose. And I would like to say that that's hard to do. And the truth is, you don't really want to do that. You don't want to put someone else's nose on your face. There may be features of that person's nose that you like, but honestly, it's interesting because what I actually see more of is they're just picking a really beautiful person. And oftentimes the nose is like unremarkable. Like
Yeah.
average nose, not like, oh my, that is an amazing nose. Once you actually look at their nose, I'm like, nah, that nose isn't that good. But the person is so good looking that you're just not even really looking at their nose. But once I start dissecting, okay, what is it about this nose that you like? No, they just like the entire face of the person because they're so good looking. People pay them money to take pictures of their face. So that's a very tall order to achieve that kind of result where you're so good looking that people want to take photos and pay you money. I can't just say, yeah, I'll give you Kylie Jenner's nose. I feel like she was a popular one for a while there because you like her nose. You're not getting these patients, Chris?
Uh, not very many, but I think a lot of times actually people have taken a screenshot of a selfie and then use the markup
Oh,
tool and they'll
yeah.
draw on their nose kind of like, especially for the dorsum, right? Like for the what people call the bridge of the nose, right? They'll always take a profile and kind of erase,
Yeah.
yeah, right. But that because then I can go over with them the concept of super tip break, because
Mhm.
I think a lot of people, what I always tell my patients is that the textbook says that a small super tip break is a desirable feature.
Tell our listeners what that is.
And so, yes, so the super tip break is basically on the bridge of the nose when it comes down from this part, the technical term is the radix. Here's the tip. Super tip break is right here. So if you have a hump, obviously you don't have a super tip break at all because the hump comes down to the tip, right? You would have also no super tip break if it came straight from the radix to the tip. But what the ideal aesthetic, as we were taught, is that it should come from the radix to the super tip break, and then the tip should project out just a little bit more. Well, so I was just going to say that one of my patients wanted a smaller nose that really would not fit her face, right? She was a very beautiful woman, but she just had very strong facial features, right? And
Yeah,
she
so she
came in
didn't have
saying
a danger nose, right?
she wanted a dished out, that was her term, dished out nose. And
Yeah.
so we went over how that just would not fit her face. And so I always tell this particular patient that if I had a website, I would love to have her photos. So ultimately, the when we took down the hump, there was just a very small little bump remaining, and it was there for sure, right?
Mhm.
And so I think her expectation was that her nose was going to be perfect, and she should have that if that's what she wants. But
Sure.
really, what she would always tell me is, when I take a selfie in this particular angle is when I see this bump. And I mean, so anyway, we went back and just filed. It was a really minor revision, but nonetheless,
So
that's a
that
hard.
you could do that closed, right? You did the filing closed.
That absolutely we did that close. Actually, to be honest with you, she didn't want to pay for the anesthesia, so we did it awake in the clinic. And I will tell you, I do not know, like numbed it up, and she had taken one of narcotic pain, oxycodone. Um,
Yeah,
I don't know if I'll ever. I don't know if it was worse for me or worse for her, but I don't know
that
that
was
I
fun.
will ever. Yeah, I wouldn't know if that I would ever do that again. But yes, that was a closed, correct,
The
closed
worst thing
technique.
I did a fat transfer to someone's lips under local. That was terrible.
Yeah, yeah,
Like
that
it,
would.
like if you numb them up, then they're going to be puffed up, and you can't tell where you're going to add stuff.
Yeah, yeah.
Same thing with you.
Uh,
If you totally blast the nose with local, then you're that little tiny micro bump, you're not going to be able to see it. So
that.
yeah,
Yeah,
it can be challenging.
yeah.
Okay, so people say this to me all the time, and I feel like it's a common adage, but I would like to dispel this, that the nose and the ear cartilage continue to grow throughout your life. People always say that. They're like, yeah, well, my nose has gotten bigger, because it does. I'm like, no, like, they're like, yeah, it keeps growing. I'm like, nah. So, I just want, yeah, it doesn't.
Yeah, it gets
Your nose,
droopy. It gets
thank you.
droopy.
Obviously, you lose some collagen and elastin fibers, and gravity does its thing on everyone. So some of the tautness or the support structure of the nose definitely can make it look droopier. The other thing I was thinking, it might be like a sebaceous skin thing. Some people have that really thick sebaceous skin, and if you have that skin, like maybe that looks thicker, approaching a rhinophyma type nose, and maybe that would make your nose look bigger. But I think I don't know about the ears. Like, why would your ears look bigger?
I,
Just
I,
maybe
I'm
just like everything's just lax and everything is just falling down.
Yeah, and the maybe the earlobe, right? Because it just, especially if you wear if you're wear large earrings, or where I live in Portland, Oregon, right? Like where people like to put
Gauge.
gauges. Yeah,
I do a fair amount of gauge earring repairs because it's not a good look. I don't like it.
yeah. It's tough when you want to.
If you want to like look elegant or conservative, a giant gauge earring doesn't pull that off. And also, if you aren't wearing the earrings, it looks like a creepy stretched out hole. So,
Yeah.
like a public service announcement to all those considering gauge earrings, please don't. Okay, so let's talk about the functional benefits. Like, what are some of the functional reasons why someone might be undergoing a rhinoplasty?
Uh, I guess poor air movement, right, is the number one thing. So, especially one side versus the other, I think is really.
Maybe septum is what everyone comes in to me. People come in saying, I've been told I have a deviated septum. Are you,
Yeah,
I'm
yes.
assuming you see as well, right?
Yes, but a lot of times they'll just say like, "Oh, I just can't breathe on this side." So a younger, less mature population, so they maybe don't even
Yes. Know
know
the
what the
word.
septum is. Yeah, or or another thing is like a nostril rim collapse. Right, we would say external nasal valve, but like if some patients have the issue where when they breathe deeply, the the nostril rim will actually close down. So I feel like that's a concern that I have dealt with.
The other thing I think, well, so there's like the soccer patient you're talking about, like the traumatic things. So having your nose broken, that can actually fall into the functional realm. So restoring a traumatized nose, most people would consider that to be a functional rhinoplasty as opposed to truly cosmetic because of the trauma. The thing that I see a lot too are the enlarged turbinates, and that's back to your airflow comment. So if you come in saying, "Oh, I have a dorsal hump, and also, by the way, I don't breathe that well in and out of my nose," your plastic surgeon is going to be looking on the inside to, and obviously do an exam that involves evaluation of the outside of your nose to see what is all in play. Is the septum, the midline structure, is it midline or is it bowing off to one side? Are those turbinates, which are the bony humidifiers of your nose that warm the air and actually humidify the air, are they too big? Are they too big on one side or too big on the other side? When you take in deep breaths, like you mentioned, are the valves collapsing? All of those things are going to be evaluated as part of your assessment. Obviously, there can be other things that can contribute to nasal obstruction. And I do have a background in sinus surgery, but I'll take down a concha villosa if I'm feeling up for it, if I really need to. But I'm not messing with the frontal recesses and the sphenoid sinuses and the maxillary sinuses. I'm not really doing that kind of stuff so much anymore. But if it's directly in the pathway of basically your nostrils to your nasopharynx, that would be something I would potentially, if there's like a septal spur, right? Something that's obstructive in that pathway, that would be addressed.
Yeah, I agree. How do you manage the turbinate hypertrophy, right, or enlarged turbinates? One of the ways is to actually just reduce it, like remove some of the bone from underneath the mucosa, the pink lining, or
Yeah.
or infracture, right?
I like the submucous resection because I want to maintain obviously all the functionality of the turbinate. I actually saw someone not that long ago who had empty nose syndrome, and for our viewers or listeners, that's something you don't want. Where someone had taken out all their turbinates and like a fair amount of their septum, it was just awful. I felt so bad. She's basically a nasal cripple, and she came in to like have her septum reconstructed, and I said, "Wow." Like that would be a big surgery. Honestly, you would have
Yeah,
to be doing like a free flap and like you can't get anything that thin. I told her she should just do a like a little septal button. It wouldn't be a little, it'd be a huge septal button. But no, I mean, whoever, this poor lady, whoever had done her surgery, did her disservice for sure. But yeah, I like to maintain the function of the turbinates, which is there are structures on the inside of the nose that warm the nose, moisturize the nose. And so the idea is to not really disrupt the mucosa, which is the part of that structure that does all the work, that you're taking down the submucosal tissue. So the bone and the tissue underneath the mucosa. So I make just a little incision on the face of my inferior turbinate, and then I use a microdebrider blade to debulk it and remove the volume.
yeah,
It's easy.
yeah,
Yeah,
yeah.
I don't really do I've tried the I think that bipolar thing isn't as good either. Have you done that? We shove
I,
the bipolar thing and then burn it.
I have seen it. I have seen it done, or like the electrocautery, like
Mm,
the needle tip Bovie, and to reduce it. So basically, you'd be burning or the tissue to.
yeah.
Um,
I'm not saying it's bad, but I just think it's less precise than just literally chomping up and sucking out the extra volume. So.
yeah, I agree. I agree.
Oh, so another misconception is that rhinoplasty is particularly painful. I would say no, I don't think it is. And the reason being is that the nose isn't particularly mobile. Once you have a body part that you're moving around a lot, like your arm or, it's like it's not weight bearing, it doesn't move very much. The annoying part of recovery is probably the obstructive part in that first week after surgery, when you have so much swelling and crusting and you've got dressings or stents or splints on the inside, that your ability to breathe out and in from your nose is actually worse. So during that first week, you might find yourself definitely mouth breathing. I would describe that as pretty annoying, but not painful. What has been your experience? Like, what do you think about patients' pain and rhinoplasties?
I think they do. I mean, I don't write for more than 10 tablets of oxycodone because they
Mm.
just Tylenol and ibuprofen is plenty. Maybe at night, right, to help them sleep. But the one thing that I really tell all the patients is that, and sometimes it's nice to overpromise and not under, but
Or
oversell
deliver
something.
under promise. Yeah.
Yeah. Because I really tell them that like nobody likes the stents that go in the nose, the soft silicone elastic. Do you use Doyle's?
So I usually do, but not always. If I don't
Oh,
do a lot of sectional work, then I might just put some like sutures in.
okay, but yeah, and I just let them know that it's just going to be uncomfortable, right? Like, but not painful. And I always say,
Mm.
it's 1 week of your life. They'll come out. You'll be so happy that they're out, and you'll have made it, right? After that 1 week visit, I feel like patients are really so happy. I don't know what your follow-up schedule is, but I usually see them at week 1 to take out the sutures and the dressings, and I always see them the very next week. Um,
Mm.
I mean, sometimes I wonder if I should bump that back, but then I just depending on how, right? Because it's really so much better at the 2 week mark. I mean, a lot of the swelling has gone down. And so sometimes, that
When
lets
do you
me know
see
if I
more
should,
than that?
well, it depends on what our concerns are. Like, if we have any concerns, right? Because sometimes there could be swelling or some mild asymmetry. And I don't know if you use steroids after like a steroid injection. But if I see him at 2 weeks and I have a concern, then I'll see him back at the 4 weeks post-op mark. If I don't really have a concern, everything looks good, I will see them 4 weeks after that, so at the 6 week post-op mark.
Yeah, I
Uh,
do 1 week and then 1 month and then 6 to 12 months.
yeah,
If there's anything atypical, obviously, just like any other surgery, if there's something that needs extra attention or I want to keep my eye on, then it could be additional visits.
yeah, yeah.
Uh,
And that's the thing. A steroid injection is something that really might warrant an extra visit, right?
yeah. Now, do people come in saying they don't want a Michael Jackson nose to you?
uh yeah, yeah, absolutely. Right. Like that that's funny. But
I mean, it's definitely a thing that people
yeah,
worry about that. Like, I just don't want to, I just look, doctor, I don't want you to give me the Michael Jackson special.
yeah. I mean, and I feel like maybe I'm fortunate in this that other than my patient that I told you that wanted a dished out nose, most people say
Right.
they want to look like themselves, just a little more refined, right? So that is the not having a Michael Jackson nose is a huge concern.
So Michael Jackson, I don't know how many surgeries he had. I mean, multiple, like
Multiple.
multiple surgeries on multiple body parts, but specifically on his nose, multiple surgeries. I want to say surgeries that were just tightly spaced in time as well. Sometimes when someone has a celebrity, they feel like, oh, I should break the rules for this person because they're VIP. Well, like, that's definitely a person you should not break the rules for.
Yeah,
Because there's a reason why there are rules, because it's about trying to get good outcomes. Just like he was getting propofol drips at home, like don't, like, bad idea. So, multiple people making bad ideas for this poor gentleman, but for his nose, too many surgeries, too close, trying to achieve something that doesn't really suit his face, right? He had the classic, what is it, to platy rind nose, and they try to give him like too fine of a tip and a pinched, like so fine it's like pinched and so narrow and too much of a bridge that they ended up putting in. It's like I think he had like a silicone silastic stent that eroded through his skin. I don't know all the details, but yeah, at the end he was wearing a prosthesis because his nose was like basically a hole.
yeah,
So yeah, I don't think that's really a thing to worry about unless you are having multiple surgeries. You would probably have to be like skipping one surgeon to another and then just saying like, oh yeah, I had my last surgery like 5 years ago, but it was 6 months ago. You'd have to be committing lies of omission and outright lies to get someone to agree to that plan.
yeah. I also think even if you try to skip from one surgeon to another, I mean, you and I would know if it was a recent rhinoplasty, right? Like if it were within the first 6 months for sure, you would know because the swelling really does. I tell patients, right? Like by the end of the first 3 months, it'll be significantly better. That'll be very close to what you have, but it will improve even more so or change a little bit with time. But I also feel like anytime, the same like when I do ear pinning surgery, anytime you modify these cartilages, I feel like the cartilage just stays really quite firm. And I always tell the patients that, like, you know how you can do this with your ear or you can move your tip of your nose shortly after surgery. It's going to be really firm and you're not going to be able to do that. So I feel like if someone came in to me and were as a new consultation saying they
Sure.
wanted a
You're not going
revision,
to be fooled.
say what?
You're not going to be fooled.
Yeah, correct.
That makes me feel better. I think, again, I think it would have to be an extreme scenario with multiple surgeries to end up with that kind of nose.
Yeah.
For new technologies, I've seen in publications in the literature things like about laser rhinoplasties and the ultrasonic rhinoplasties where they're using that piezoelectric energy to make cuts. From what I understand, that maybe the cuts help reduce bleeding. I mean, it's just like people that do the laser blepharoplasty. It sounds cool, but I'm not sure that it's as cool as it sounds.
Yeah, yeah, I agree. I don't really. What do you think about other things like filler in the nose and uh,
Yeah, a liquid rhinoplasty is cool. I mean, I think the main disadvantage of a liquid well, there's two. So one of the main disadvantages is that it's theoretically temporary. I know there's a lot in social media about how fillers never totally go away. I think there's probably some truth to that, in that I don't think that they 100% dissolve even after a year or two. That might actually work to your benefit on a liquid rhinoplasty, and that, let's say you were trying to camouflage little subtle blips on that silhouette of your nose, that maybe you don't ever completely lose the filler that was added. The other main thing is that a liquid rhinoplasty is only additive, meaning you are adding volume. So you can add volume, for example, above and below a dorsal hump to camouflage it, to make it not look like a hump, to make it look like the whole dorsum of the nose above and below the bump is projecting more, and so that it looks like a smoother line. The real challenge with the liquid rhinoplasties comes, I think, in the tip. If you have a boxy tip, you can try to add some filler to the tip and maybe make it look like it's more refined, but more projecting in the tip area, but it's still bigger, right? And so if you have a really big nose and one of your goals is to have a smaller or more refined nose, filler is tough because it's just adding volume. And I think that people need to realize that.
yeah,
Liquid rhinoplasties, obviously they're done in office. It's just like other filler that people get elsewhere in their face. That's an advantage, is you walk in, you get a vial of filler in your nose, you're awake the whole time, you walk out and go home. And from a results perspective, it's nice because you can see at the end of your liquid rhinoplasty, it looks pretty close to what it's going to look like long term. Now, the next day, it's going to look puffy, maybe a little bit crazy, and then it calms down again, just like anything. It's a fun procedure and it's easy-ish. I mean, easy-ish.
yeah.
Oh, back to the Michael Jackson nose and the different nose types. And then what you were talking about before with regards to that lady wanting a super scooped out nose. One of the plastic surgeons that I train with, he didn't have a blue plate special for rhinoplasties, but kind of. Like everyone got the same, everyone got the super scooped out dorsum. And I remember he would take a chisel to that dorsum and just take out like a good 4 or 5 millimeters, and I would be like, oh, but
Yeah,
that's a lot.
yeah. I agree with the blue plate special. There's a plastic surgeon where I live that I would say not just the right. Like sometimes you see patients and it's like, oh, this person has
I
had a
agree.
Dr. So and so nose job, or this person has had a Dr. So and so facelift because they just all look the same. I think that's actually an important thing to discuss with your
Yeah.
surgeon, what exactly your goals are, and that like You want to be you still, just
And as
enhanced.
for the dorsum, the one question I always ask women, because for men, the ideal dorsum is considered pretty flat. But for women, like if this is a plane between the top and bottom of your nose, it's considered to be ideal to be maybe even a little bit, not that scoop, but like a couple degrees under that straight line. So I always ask women that have a dorsal hump if they like what their ideal is. Like, do they want it to be kind of straight or they want it just a little bit under? I feel like most women do like a little bit under that straight line.
Yeah.
And most men are going for a straighter line.
Yeah. That's a super tip break that we talked about before, right?
Yeah.
Yeah.
Well, I mean, you can still have your super tip break, but how much you have, like, is it like this? I mean, no, not like this, not that scooped
Okay.
out. That
Yeah,
looks
I see
bad.
what you're saying. Yeah. Ski slopes.
Um, no one likes that. I mean,
No,
actually, maybe some people do.
yeah, I mean, I feel like that's terrible, but one of my in like in high school, one of my buddies would make fun of some other kid and call him ski slopes. So like it's definitely something you don't want.
No. So for the catarrhine, which is the classic Caucasian nose, we're often doing maneuvers to reduce dorsal humps and rotate tips up to avoid that bumpy downward rotated tip. But in other ethnicities, like the Platyrrhine nose, where the dorsum is a little bit flatter, the columella is not as projecting, it's shorter, the ala or the nostrils are a little wider. Just depending upon what that patient wants, then oftentimes we're doing different maneuvers, like we're doing things to build up the dorsum, we're doing things to narrow the ala, we're doing things like you were mentioning before, Vita Wise to lengthen the columella. So obviously it's very important to discuss these goals with your surgeon so that the things that you are concerned about and that you want to address are incorporated into your plan. And I certainly can recommend that to everyone. A rhinoplasty, yeah, it's not a blue plate special for most surgeons. And we're doing different techniques to achieve different things based on, A, where the patient started and B, where they want to end up. So I think any kind of surgeon worth their weight would be doing that for you. And patients are smart, making sure that your surgeon is incorporating that and making sure you understand what they're wanting to achieve. Again, it gives you a higher chance of having a successful outcome. That is another advantage for plastic surgeons that do primarily aesthetics or cosmetics, is that most of us do have websites because that's how we get business. Dr. Zarella here is lucky to have lots of referrals and doesn't need to show his work. He's good. I'm sure a lot of it is word of mouth, and that's the best kind of referral. He's got patients that are going back to their primary care doctor and being like, yeah, that was really great what Dr. Zarella did, and I'm really happy. And so then, said doctor is saying, okay, now all my patients I'm sending here. So that is a great way to do it. Or just like word of mouth, like, oh, this 17-year-old kid had this done and he talked to his friends. Maybe, I don't know if 17-year-old kids do that kind of stuff. Like they probably don't even remember their surgeons' names. Maybe they do, maybe they don't.
They probably
Like
don't.
my parents took me, I don't know, I had to do it.
I think also though I have a fair number of patients. Like one compliment that I got that I thought, I mean, I took it as a compliment or was a comment was, I mean, the nose. It was this this young woman that I did a rhinoplasty, reduced a boxy tip, took down a dorsal hump, did some functional components as well. But she still looked like her. I mean, her nose looked completely different to me, right? Because
Mhm.
as a plastic surgeon, but she still looked like her. And the mom, what I loved is at her final visit, that her mom said, this has been the best because we haven't even had to tell anyone that we did this, right? And
Oh, that's nice.
it
Yeah.
was really nice. Yeah. So I think also maybe it's a little tough to get word of mouth referrals in that way because people don't want to, some people really don't want to advertise that they did it. Right. And so,
Mhm.
so I am fortunate that the pediatricians that refer to me trust me.
I feel like you're right. I think most people don't want to share, but there are some people that are very open. I literally, the other week, I had a guy who had a facelift neck lift done, and that same day he had talked to several of his friends, and his friends were already calling my office because they're like, oh yeah, this guy had it done, so that's where I'm going to go. And so, yeah, those kinds of scenarios arise where the word of mouth is really strong. Part of the challenge for the face is that with regards to photo sharing is that there's no anonymity. Like if you are sharing your face photos, then all right, You're pausing a really funny expression, so it's making me laugh. Let's see. All right, Dr. Zarella is back on. He's back.
He's back. Yeah.
Better.
Sorry about that.
Yeah, you were paused like this.
Well, I still can't see because so I don't even want to know if I had a terrible face or something, probably looking stupid.
No, I think you were just in the middle of saying something.
Oh, gotcha. I know. So I miss what you're saying.
For the face, I think it's a challenging area because some people are really open and want to share all kinds of minutia about their surgery and their personal life, and some people really don't. It's different for other parts of the body because there's an anonymity component with regards to sharing photos. But the face, for me as a surgeon, is more challenging because it's harder to share the photo and also not reveal that, oh, I just had a rhino, I just had a nose job, or I just had a facelift. And not everyone wants to share that. And that's fine. I think that's your prerogative. I love when people want to share because that helps me and it helps other patients. But I also get why you don't want everyone to know your business. Like I get that too. So whatever, I mean, whatever people want to do.
Agreed.
In closing, I would say rhinoplasties are a popular surgery because we're in an age of social media and constant feedback to seeing our own face and the symmetry or lack thereof. And traditional surgery does the best job at addressing those theoretical concerns. Yes, you can do things that are a little bit less involved, like a liquid rhinoplasty, and that could be helpful. And I'm not saying you can't rule that out, but my best advice to someone considering any of these options would be to meet with a board certified plastic surgeon or a board certified facial plastic surgeon and someone who does noses specifically. And I don't think every plastic surgeon does rhinoplasties, but I think probably every facial plastic surgeon, I mean, probably most of them do rhinoplasties, but not every plastic surgeon. I think for some people, your training is not as in depth as you probably would want it to be, and perhaps you never gain that comfort level. I mean, for you, for craniofacial, obviously you spend a lot of time in the face and the nose, and for me in ENT, same thing. So I don't think we're the typical plastic surgeons as far as training goes. But yeah, so for those patients that are thinking that they want to know more about rhinoplasties, meet with someone who does that, look at their credentialing, look at their training, look at their photos if they happen to have them, listen to your friends. People are much more likely to follow the advice of someone they know because they're a known entity, like they feel like they can trust them. But yeah, sometimes photos can help in that regard. If you flip through the photos and you're like, yeah, that's good, that's good, that's good, then that person might be a good fit. If you look at the surgeon's photos and you say to yourself, I hate that, and I hate that, and I hate that, then I probably would say, don't go to that surgeon. And I tell my patients that all the time, like, how do I know if I'm going to like the scars? I'm like, well, look at all the photos on my website. If you hate every one of those, then like either the surgery is not right for you, or like maybe I'm not the surgeon for you. But if that's not the case, then you'd probably be okay with it. If you think that in general, the outcomes that other people have experienced, if that were you, that you'd be satisfied, that's probably a good fit. But if you think that you would not be satisfied were that to be your outcome if you were that person, then no, don't do it.
Yeah. I agree.
So if you guys have any questions or thoughts or ideas, feel free to leave us some feedback. But otherwise, thanks for tuning in, and thanks for coming on, Chris.
Yeah, thanks so much for having me. This was great. Yeah, I appreciate it.
Okay.